Hello and welcome to a very special interview at The Wire. We're speaking today with Dr. Soumya Swaminathan, who's currently the second in command at the World Health Organization. Up until the end of this month, Dr. Swaminathan is also the head of the Indian Council for Medical Research, ICMR. Congratulations, Dr. Swaminathan. It's a big deal for India to be represented at the WHO, and I think also a big deal that a woman will be doing that representation, so I'm particularly pleased about that. So let me begin on your appointment to the WHO. This team that Dr. Tedros has, I think is special on perhaps two grounds, one being democracy and one being diversity, because it was the first time that the DG was elected, and he's putting together put together a team which he's very proud of because it's 60% women and has representation from 14 countries. So in terms of both democracy and diversity, this is a very important team. What does it mean for you to be part of this team? You know, not the previous team, not the next team, but is there a special significance to you being part of this team?
Yes, thank you very much for that question. I think it's of course a great honor and a privilege to be selected for this position and to be nominated by India. I think there's some very special, it's a very special moment right now because for the first time we have an African DG of the WHO, and that's a big thing. And as you said, we have a leadership, the deputy DGs and the assistant DGs are from different parts of the world. They come from different backgrounds. Of course, 9 of the 14 are women, but they also have very different life experiences and stories to share. So I think that this is an opportunity actually to really look at the way WHO has been delivering and perhaps look at a renewed WHO that focuses more on impact on the ground, that engages much more directly with countries, and that singularly focuses on improving public health and the health of the millions. And Dr. Tedros has very clearly explained his mission and vision, and this new team is already working hard to be able to achieve those goals within the next 5 years.
Mm-hmm. With regards to India's role at the global health table, we come with a lot of baggage, and you know, we've got the largest burden of TB. The global hunger index that recently came out has put India at the bottom of the index. We're literally scraping the barrel. You know, after so many years, we're still scraping the barrel on this. The Indian media has coined a phrase called death by breath, wherein it's literally apparently possible for us to die by simply breathing. I mean, pollution is so high that it's visible and it's tangible. We've seen deaths of babies because they're not getting oxygen supply in government hospitals. So this is the kind of baggage that India carries. And I'm just wondering, after all of these years, and India is also trying to project itself as more than just a developing country in need of aid, how should we project ourselves at the global health table? Are we a giver? Are we still a receiver? What are we contributing and what are we still taking?
Yeah, I think it's a very complex question that you've asked. No doubt that there are all these scenarios which are still quite bleak, we could call them bleak, and that need a lot of attention. However, I think you know, we've also shown that we can, once we set our minds to it, deliver. And I just give you a couple of examples. We've brought down the total fertility rate to 2.2. Of course, there's still a few states which need to come to that, but essentially we're achieving replacement level fertility fairly uniformly. We've eliminated polio, which nobody thought that India would be able to do. We've eliminated tetanus. When I was training, I remember the number of babies that I used to see with neonatal tetanus, and it's really a horrible way for a baby to die soon after birth. We've achieved the Millennium Development Goals on infant mortality, again something that people were not sure whether we would do. So I think in the last 10 years that we've had the National Health Mission with a focus on maternal and child health, we've been able to make a lot of progress there, and with immunization. But yes, we still have a huge amount of health challenges. Our population and our heterogeneity and diversity, both in terms of health systems performance, varies so much from state to state, and also in terms of overall health spending. I think we really need to move up rapidly on those fronts. So health workforce and health system spending to ensure universal health coverage becomes a reality. I think that really needs to be the goal for the next 10 years.
I want to address something that's a bit more imminent, which is the situation in Zimbabwe, and it had a bit of, and it's important because of what has also just happened in the WHO, which is that President Mugabe was appointed as WHO's goodwill ambassador for non-communicable diseases. He has been the president of Zimbabwe since the 80s, and currently there's a quote-unquote coup undergoing, that Zimbabwe is undergoing, where the military has already taken control of state TV and has detained the president. When he was appointed, there was a huge outcry by the global health community, and their objection was that a man with poor credentials on democracy, human rights, and on corruption, how is it possible that he can be made a goodwill ambassador? And now we're having this mess of a situation, and it so happened that this was the first crisis that you had to really deal with, your team had to deal with. But the WHO took the decision that you would rescind his ambassadorship. I think there are still people who'd like to know, especially in light of this current emergency situation in Zimbabwe, what was the thinking in WHO? I mean, surely there are protocols, and surely there was someone who was vetting the candidates. How is it that someone who can have a poor record on democracy, human rights and corruption, but perhaps has a good record in non-communicable diseases, can be made a goodwill ambassador? What happened in the vetting process?
So I wasn't there, and in fact I still haven't officially joined the WHO, so I won't be able to really give you a lot of details on what happened. I think the DG did make this announcement at the big NCD conference that was happening in Uruguay, and I think the aim was that Mugabe has been a leader in the southern part of Africa for many decades. He has influence within Africa, within the African region, and apparently there are a lot of people who do listen to what he has to say. So I think the idea really was to use a voice that is a loud voice, important voice in the region, and to try and use that to deliver a good message. However, I think after the outcry, there were things that came to light about his own contributions and some of the things which were directly in conflict with WHO policies. So it was rescinded. But I don't have any more insights into that episode since I wasn't there.
I mean, Mugabe is 93 years old, so his own health is considerably precarious, and he apparently doesn't use his own country's healthcare system. He's often in Singapore for his own healthcare. But on that, I mean, what do you see this as an embarrassment that the WHO had to deal with this, the new team had to deal with this soon after coming in? Or in hindsight, are you kind of relieved that you listened to the global outcry?
I think one has to learn from these kind of incidents, and so possibly in the long run it becomes a learning experience, and one would need to think very carefully. I mean, I think for a goodwill ambassador, especially for an agency like the WHO, one has to check on a number of different things, and political affiliation is one thing, but also I think your own achievements and your public face is very, very important. So I think going forward, obviously we would like to have many more goodwill ambassadors for health. I think it's very necessary to have advocates for health and people who are from outside the health community, because we end up talking to each other, and so you need celebrities and important people to be talking about this. But that the individual who's chosen, obviously I think will need to meet a number of strict, very high criteria.
So better parameters, more holistic parameters hopefully.
Parameters and perhaps more consultation.
Okay. Let's talk a bit about TB, because India has the world's highest burden of TB, and much of your work over the last 25 years has been on TB and HIV. India has set a very ambitious goal of eliminating TB by 2025, and the WHO's own goal is 2030, but India has said we'll do it by 2025. What perspective should we see this goal? How realistic is it?
If you ask me as a scientist, then I can tell you that it's probably not feasible to eliminate TB by 2025 given the tools that we have today. However, I think there's a value in having this kind of an elimination target. It fires the imagination of people. It brings people on board. There's political commitment at the highest level. I've never seen anything like this, frankly speaking, in the last 25 years on TB. We've always been fighting for TB. In fact, we haven't had that kind of civil society demands that we had in the HIV globally. It's not just in India, and I think that's one of the reasons why TB has been forgotten. It's a poor man's disease. It kills slowly, chronically, and it never makes frontline news, unlike dengue or H1N1, where even one death makes it to the front pages of newspapers. So that way I think it's hugely energizing to see this, and to have the Prime Minister and the Finance Minister even talk about TB elimination shows a great, it shows commitment at the highest level, and that's the first thing you need for any disease control program to succeed. Now, whether we achieve technically elimination or not by 2025 is a moot point, but I think what we need to focus on today is the roadmap. There's no point just repeating the fact that we're going to eliminate TB. There needs to be a very clearly articulated roadmap with practical actions and a large number of stakeholders involved, and I think that has been laid out in the National Strategic Plan. It's been fully funded, it's been budgeted, so of course the funding needs to come up. But very importantly for TB, unlike other infections, we still need new tools. So the investment in research is very important. For malaria, we've got a rapid diagnostic test. You can get a blood prick and a report within a few minutes. We have a 3-day course of treatment and you're done. And similarly for most infectious diseases. But for TB, a diagnostic test takes a long time. We have molecular tests now, but they are not still available to everyone. Your treatment has to go on for a minimum of 6 months. If you have drug resistant TB, for 2 years, injections, painful, toxic, anybody would lose hope and give up treatment. So that's the challenge, and we don't have a good vaccine. Polio could be eliminated because of the vaccine. So on all three fronts, diagnostic, drugs and vaccines, we have a long way to go in terms of new drug discovery. With drug resistance coming up, we will need a pipeline of new drugs. So this is where India has to step up. I think along with other BRICS countries, we should no longer wait for other countries to do the research. This is a disease that affects us. 1/5 of the world's TB is in India. TB cannot be eliminated globally unless India eliminates it. And I think that's where the ICMR has been advocating for increased investment and increased cooperation and networking globally on a mission mode to develop these new tools for TB.
I completely agree with you that it's very important to see commitment at the highest level, and for that commitment to be very vocal, which I think the government has got down pat. That's certainly happening. And also the fact that India had been underreporting this for a very long time, which we only recently discovered, that for about 15 years we were underreporting. So it's one thing to now increase, monitoring of cases and finding out of new cases, but that simply just increases your burden. And is that, so you have a demand supply issue going on here, and then is that burden being met not just with the political commitment that you're talking about, but operationally what is it that we can say that we have done so far? I mean, we've announced the deadline, but since then and now up until 2025, operationally, what can we say is happening?
Yeah. So there are a number of different things which have actually happened and which are continuing to be rolled out quite rapidly. One is diagnostics. So we were still depending on this microscopic examination of sputum smears. It's very insensitive, and it all depends on who's doing it and whether the microscope is functioning or not. Now the aim is to have a molecular diagnostic, a PCR test available, which is point of care. It's been made by an Indian manufacturer. We validated it. Can actually be kept in the primary health center and be used to diagnose not only TB, but the same equipment can be used for other infections as well. So if we're able to do that, then every possible patient with TB would have a test done, which would also tell about drug resistance. So you'll start diagnosing many more people. Second is the private sector. The reason we were underreporting is that even today, about half of the TB patients in the country are being managed in the private sector, either by qualified people or maybe even by quacks and unqualified practitioners, and we have no idea what's happening to these patients. So this whole concept of notification and reporting only in the last couple of years has picked up. It was made mandatory in 2012, but it's taken several years for it to really pick up, and now we are seeing a couple of 100,000 cases being notified every year. At least slowly that will tell us how many patients are out there. Thirdly, I think we've moved to a daily regimen, which means we don't expect people to come 3 times a week. We're going to give them the drugs, but of course we also have smart ways, IT-based monitoring systems where we can keep track of who's taking the drug and who's not. And finally, there's going to be now social support and incentives built into the program, so that for every month that you are regular with treatment, there'll be a cash transfer into the account of the person. So that will help them with some nutrition and some food and so on, and hopefully serve as an incentive so that they'll complete the full course of treatment. And there are other kinds of support mechanisms also being considered for TB patients. So this whole package is fairly a holistic package. It looks at all aspects of the patient, including their own social and economic needs that they have, and hopefully will help to turn around. But the private sector engagement is one piece that's still, I think I would say, relatively weak, because the government has a good structure and the government expects the private sector to collaborate. Patients have their own views about who they want to seek care from. So for many reasons they may prefer to go to a practitioner who's sitting in their locality till 10 o'clock at night rather than a government clinic that works certain hours. And the private sector believes that the relationship between patient and doctor is sacrosanct, that there's confidentiality to be maintained, that there's no need to report, and so on. So bringing these different viewpoints together and convincing everyone that the only way to eliminate TB from India is if all these constituencies decide that this is an important mission for which we have to collaborate, like we did on polio. Everyone came together. So we're trying to do a demonstration project in Chennai to see whether we can actually set up centers of excellence within the private sector, within private practitioners, and say, okay, don't refer cases to the government, there's no need to do that, but we'll give you free drugs and free treatment. Let the patient benefit, so that patient is not out of pocket expenses. At the same time, you need to tell us, report these cases in, follow them, make sure they complete treatment, and tell us what happened after 6 months. So this gives them their, we're not interfering with their practice or with the patient-doctor relationship, but at the same time, for us, what's important is that every patient should be diagnosed using proper methods and treated till they're cured. And the family members need to be traced, and because very often you find about 3 to 4% of family members have TB. So it's very important to do the screening. Yeah.
Right. What you're saying about the private sector involvement, I think India's health and education sectors are both trying to grapple with this in its own unique ways. Now, it is true that in India, despite our high levels of poverty, the preference for a lot of people actually is the private sector. I mean, the data is certainly showing that going to a government facility is not people's first choice, even if it entails great economic hardship and out-of-pocket expenses for them. But given that TB is a particularly it's got its own uniqueness. Is India's TB burden better serviced if it is more consolidated in the government sector? I mean, is that kind of what you're saying? If the private sector is not cooperating because of whatever issues that they have, is it better serviced with a consolidation in the public sector?
That's something that we have been debating, because there are countries like Brazil and China where TB drugs are not available outside of the government sector. You can't just walk into a pharmacy and buy TB drugs, and that in a way helps to completely control the thing. Everybody who has TB has to come into the reason it hasn't been done in India, or we have not really thought that was a serious possibility, is because of the huge geographic reach that you'd have to have for delivery and for access. We cannot afford to have any situation, any corner of the country where a patient ends up with no access. And there are large parts of the country even today that are only serviced by private practitioners, or at least geographically very far away from a government health center. So that's one of the reasons why that step hasn't been taken. But this has been on the table for some time, and I think it needs further discussion. It would certainly help cut down on misuse of anti-TB drugs. So it would help perhaps curtail drug resistance emergence, and secondly, it would ensure that all TB patients got standardized treatment, standardized follow-up and diagnostics, and that they were all recorded into our system, so we would be knowledgeable. So the only downside is, what if some people are left out of this? So if we get to the point where we are confident that we'll be able to reach everywhere, then I think this is actually a good thing to do.
To consolidate it a
Yes,
bit.
to consolidate it.
Yeah, because in TB the follow-up and the keeping to the regimen is very important, especially that we are now also dealing with drug-resistant TB, and that's an irreversible situation. But when you say that it's important that every part of the country has access and no part of the country should feel like you don't have an option. If we can talk then about the situation with bedaquiline and delaminate, because this is the one drug that is coming after decades, after about 40 years. It's an option and it comes with problems, but yet in India it's only being available in 6 centers, and that too you have to be a domicile living within 5 kilometers of those centers. It's only in big cities, to the point where, as you know, earlier this year there was an 18-year-old young woman who in her diminished state had to keep coming from Bihar to the Delhi High Court just to get access. I mean, the court had to give her access even though there's a government program for it. But every TB patient cannot come and do this on a one-by-one basis. So what is the hold-up? I mean, we even the supply of bedaquiline and delaminate is a gift. It's coming to us from USAID. There's not a high level of procurement happening. Even if there is, there's not a high level of rollout happening. So what is the not happening over here, and how do we untangle this?
So I think in the beginning why it was restricted to these 6 centers was because of the concern of the toxicity of bedaquiline and the necessity to observe these patients very carefully. So 6 big centers with capacity were selected. However, this was very soon after the first 300 patients or so had been given treatment, and it was clear that the drug was tolerated well, that there were no out of the blue side effects. It was scaled up to all those states. So while there were centers were there, but the patients across the state were permitted, and now there is a nationwide access. So the program had to go state by state, training all the staff to do this, because you need to monitor them for certain side effects, so there needs to be a pharmacovigilance program built in. So there's fair amount of training that needed to be done, but today I think there's no question of there's no problem with access for any patient, but we have a donation from USAID, maybe up to 10,000 courses. We've had the first installment of 2,000, another 2,000 now, but I think we have to think long term, what are we going to do, because we have over 1 lakh patients who develop MDR TB every year, and maybe about 8 to 10,000 XDR TB that desperately need not just one but perhaps both the new drugs. So the donation for delaminate is only 400 courses that the company has offered to the country, and bedaquiline is up to 10,000, but this is not going to last very long. So I think we need to start thinking about the strategies, and there are a couple of options, but the government would need to discuss that with these companies to ensure that continued access, because if we start access and then we
Have to keep it going.
have to keep it going. Yes, have to keep it going. And right now, as I said, there are no other alternatives. We need both these drugs in order to give these patients a good chance of survival.
So when it comes to TB, you're talking about the important role that the private sector is playing, and earlier on in this you just mentioned that NGOs also need to be taken on board. And on this, I want to ask you about tobacco, because tobacco control is a stated policy of the government. We hosted the last framework convention on tobacco control last year, this month, November last year in India. The health minister has been given an award by WHO for his work on tobacco control. So supposedly this is a big thing and we're completely on board, yet we're seeing NGOs, organizations that work with the government to implement the government policy, are being asked by other government agencies, the home ministries, security agencies, why they're working on tobacco control. So what is the tension? What is it that is so difficult for other agencies in the government to understand? Why is there no communication happening between the health ministry and other ministries?
See, I think it's hard to really generalize, because we know that as far as the FCRA status of NGOs is concerned, the Home Ministry has recently reviewed the FCRA status of a number of organizations, both government and NGOs, and put out a list of those who were not complying with. Some of them were minor irregularities, some of them were a little more major, and the ones with the major irregularities that have been pointed out, obviously they know the details, we don't, and they have to provide satisfactory explanation to the Home Ministry. So I think we can't take a a very generic stand on this. But as far as tobacco is concerned, I think one thing we all have to realize is that the tobacco companies are just huge, and the kind of machinery they have, the kind of resources they have, and the kind of tactics that they are willing to use to further their interests, I don't think we can even begin to imagine or fathom, and at what levels they are able to operate. So this is where I think we are rather naive. We believe that everybody should think that tobacco is bad for health, and therefore it should be obvious to people and so on. But there are lots of factors here that are playing, and but I think the health ministry, I must say, has been extremely strong about this whole thing, not succumb to any kind of pressure, whether it's the pictorial representations or whether it's other doing advocacy for increased taxation on tobacco products. But then there's that other lobby that you're fighting all the time, which has money, power, and also no compunctions of any kind. So it's going to be a constant battle with tobacco, both globally and in India. And for us, we have an added problem of chewing tobacco, which actually in rural areas, among the poorer communities, is even more common than BD or cigarette smoking. So we need to pay more attention to this chewing tobacco, which is equally harmful. A lot of the oral cancer and upper GI cancer in our country comes from tobacco. So we can't let up at all on this battle. But as you say, we have to keep facing these challenges as and when they arise, and be able to speak up.
I'm just wondering if there's some sort of a difference of opinion, as it may seem, in the government, because it's not just a couple of NGOs whose FCRA could have been contentious for other reasons or whatever. I mean, as you know, a lot of solid reporting has been coming out from Reuters, including the massive investigation that they did on the WHO, on the FCTC that we hosted, and about how big tobacco companies were influencing, lobbying with government officials, even in India. And I mean, of course, this is not something that we did not know, but they showed you the entire paper trail also that led to it. And there seems to be a particular grouse with people like Michael Bloomberg, who's a friend of WHO, and also has lots of money that he's put into tobacco control in India. In fact, this was an investigation that happened a year ago, and nothing has been found, and clearly it's been leaked to a journalist now, 1 year later. But is there some sort of a misunderstanding in the government between what the health ministry thinks about tobacco control and what these other wings think?
Yeah, I mean, I think perhaps the understanding is not that comprehensive as it is within the health ministry, but I do think that government departments need to work together on this, particularly for something like tobacco. They also made a differentiation between receiving funds for advocacy and for scientific research, and not cross-using funds received for one purpose for something else. So those are very technical points which I'm sure can be clarified quite easily. But I think these are the subversive ways in which tobacco companies act, and perhaps these ministries also need to become much more aware that so that they can watch out for these any kind of, because obviously it will not be done directly, it will be done very indirectly, and it will be done in a way that may not directly be able to link them. But I think more awareness, perhaps discussion on this issue with the concerned ministries might be a good way, so that we're not slowed down in our battle against tobacco.
Let's just shift tracks to talk about medical research, because that's the work that you've been invested in for the bulk of your career. What would you say are your highlights from your time at ICMR, and what is your unfinished business that you hope your successors will take over?
Okay, so I think one of the highlights has been that over the last year and a half, we've all engaged in a process of coming out with a strategic plan and a vision document, and this clearly lays out what the priorities for ICMR are, and very clearly one of them is building health research capacity in the country, because I think that's where we're really at the moment, I would say, quite weak, and for our level of development we need to have much better strength in biomedical and health research in our medical colleges, in our academic institutions and universities. So that's going to be a huge priority for the Department of Health Research in ICMR in the future. The other one is really going to be focusing on how do we bring evidence to policy in a much more effective and strategic manner, and not have to take many, many years before we realize that we should have changed the policy a long time ago. So I think ICMR and similar institutions have an important role to play in synthesizing evidence, in convening people. I can give you an example of the HPV vaccine. When I took over as DG ICMR, I was told that we're not even going to touch HPV vaccine. This is a very contentious issue, that we shouldn't get embroiled in this. But I decided that this was an important public health issue that needs to be discussed and debated. Why are we not discussing it? So in the last 2 years, we've seen states like Punjab and Delhi actually start a vaccination program for their schoolgirls. Other states are looking at how to do it. Part of the issue is getting the funding for it. And the central government is actually considering incorporating HPV into its immunization program. So this shows that if you start discussing with evidence and with technical discussion on a technical and not on a emotional or a political angle, that you can achieve things. So I think evidence to policy is one. Implementation research is another pillar of our strategic framework. And what I mean by implementation research is how do we implement things that we know are good. So there's knowledge and there's acceptance that that's what one should do. And at the same time, you'll find on the ground it's not happening. So working for researchers, working with implementers and with the policy makers to actually show something and how it can be done in different ways, that's implementation science or implementation research. And that's somewhere where we can really show gains very rapidly. And then the other areas are around data. We have huge amounts of data collection in our country. We have survey after survey, but everything sits in different ministries or departments. There's no one place where you can go to for a health repository. So my hope was and goal is that ICMR should become the health data repository for the country, one-stop shop, and that data should be accessible to people, because these are all data collected using public funds, taxpayers' money, and therefore the information must be available to the public. So we are working on these large data systems and data warehouses where this would hopefully eventually happen. The last area is traditional knowledge, leveraging our traditional knowledge not only from our Ayush systems like Ayurveda and Yoga, but also from our traditional healers and folk healers and medicinal plant people who have a lot of knowledge on our medicinal plants, and can we actually work with them to firstly validate their claims, and secondly to maybe do drug discovery. So this is how drugs like artemisinin for malaria were discovered, from medicinal plant. So there's a lot of scope for new drug discovery. So here we need to work with other agencies like the ICMR, but also with industry, because I think without working with industry, it's going to be impossible to do any kind of drug development work in this country.
I wanted to talk about the industry angle of it perhaps just after this, but before that, if I can ask you, there was a time a few decades ago when we looked at the scape of science in India, and we looked at it with much pride, and I want to ask from an outsider's point of view, perhaps within the scientific community there's a lot of buzz and excitement, but I feel like it's been a long time since us on the outside have heard something exciting coming out from Indian science, So, I mean, your own father is someone who we would call a person of note. He was a leading scientist in his time and continues to be a leading scientist. But I feel like it's been a long time since we have been invigorated by either a person, an institute, or path-breaking discovery. So, what is India's research story? I mean, is it a generation that is past, or do we still have much to offer?
Yeah, that's an interesting question. One thing is that we have bureaucratized our institutions. So I think at that time, in the 1960s, there was less bureaucratization. Scientists had access to, say, the Prime Minister, and things moved, because once there was a national mission or a need, full freedom was given, whether it's a space program with Vikram Sarabhai, or whether it was, the atomic energy program, of course, but also agriculture, as you mentioned. These were all areas where there was freedom given to scientists, there was constant support from the political system, and so it became a reality. Science was translated very rapidly and we made huge achievements. So that I always think, if we can do this in space research, for example, building Mangalyaan and all that with the same kind of resources, why can't we do more in the health sciences? So one thing is, I think our institutions got bureaucratized, but when I look around me, I see that there's a lot of cause for optimism and hope. I see a lot of young people, very many of them trained abroad, come back to India because they actually want to work here. They have startup companies, they want to contribute, and they're doing wonderful work. I've seen some wonderful work happening around the country, and I think we just need that next in the ecosystem to be able to give them that little helping hand, and which is of course includes financial support to them at critical points so that they can make that leap.
Let me just ask you about something you mentioned, which is India's priority when it comes to biomedical research, whether it's on disease or whether it's on drugs. Should that priority be in the public sector or in the private sector? You also mentioned that you can't do this without the private sector, and we see that in the US and the UK, what's happening is the bulk of this discovery actually happens with taxpayer money in public institutions, and then it's sold off to private companies who then make it absolutely inaccessible to the public who funded it. But India is certainly not at that level. But what should be India's approach to research, public or private?
No, that's a very important question. I think that we need to have our own model, and that model should be, I think, that the government has to invest in the basic discovery. Private industry will not, it doesn't do anywhere else in the world. We can't expect our pharma industry to suddenly start doing that. So early discovery work, the basic R&D must be funded by government. And then once we create that knowledge and that intellectual property, that should be used for public good, because it's been, so unlike the US, like you mentioned, where there's a double price being paid by the public, here I think once you create the public good, you need to ensure, of course industry plays a role because they need to produce the product, but they produce it at a price which then becomes affordable for people to use. So I think
And in India, what would you say has been our approach to this? I mean, have public institutions really taken, have they been picking up the slack, or have we been sort of hoping that private players will come into it, or what exactly has been our legacy here?
We've done some. I mean, there have been drugs that have come out of the CSR system, for example, that are on the market today. But there could be many more, and it could be done much faster. So now what happens is, because of a lack of resources, somebody makes a discovery, but then to get to the next step, you need, in the West, they say that they need a couple of $1 billion to take something from discovery to a drug into the market. Okay, a multinational company would take that much. In India, we can do it in $80 to $100 million. We can actually develop a new drug. But even then, you need that 80 to 100 million to be available. For example, I know startups now who've got leads and drug molecules to fight drug-resistant bacteria. Now they need support to do their preclinical testing, the animal testing, and then get into the phase 1 human trials. And there again, we are hoping to be able to set up some phase 1 trial centers in public sector institutions in India. So I think $100 million is not a huge amount of money for a new drug, especially if it's a new antibiotic. So we have to think of investing at that scale to be able to do this.
Right, because the Indian model has, when you talk about pharmaceuticals in India, it's really been about generics. But that also means that we've been occupied with a copy model, that we're very happy to just copy what has already been done by somebody else. So, I mean, should we remain with that because that's our strength, or should we, and leave it to people who have more money, $100 billion to do this kind of stuff, or should we try and do a bit of everything? I mean, what is the most prudent thing for us?
There's no choice, we have to do it, because just doing generics, and now with the patent regime and everything being challenged, I think that's, sooner or later our population will not going to have access to the drugs we need. So we need to do more in discovery, and our own R&D ecosystem needs to be really geared up.
ICMR actually has a bit of competition these days, because some would call it pseudoscience, but there's a lot of pressure on that right now in India to put focus, put money, put policy interest into what some would call pseudoscience. And I'm just wondering what you feel about that. So we have a government appointed panel now that is looking into the benefits of cow urine and its derivatives. This has got the Department of Science, Ministry of Science and Technology on it. It's got CSIR on it. I think ICMR has been left out of this one. We also have competition from the Ministry of Ayush. We've got herbal remedies that are being recommended to prevent, not just to treat, but also to prevent things like dengue. And I'm just wondering, is there a bit of a crisis, when you say bring evidence to policy, and when you say that, there was a time in the 60s where there was a lot of interest, even political interest, in fostering these kind of things. What is the tension right now that is seeing so much of importance that is being given to things like this?
So I think the key word is evidence, and wherever there are knowledge gaps, we need to generate the evidence. If there is already a lot of evidence available, then you need to synthesize it. So as far as traditional knowledge, I mentioned to you that one of the pillars of the ICMR strategy now is actually leveraging traditional knowledge. So I think we have a lot of traditional knowledge which I think is very well accepted and validated, but we need to validate it using modern methods like clinical trials. So you mentioned dengue. So we're actually working with Ayush, with the Council for Ayurveda, and doing a clinical trial using one of their products to treat dengue patients. And
is it a homeopathic product?
No,
because
this is
I've seen
Ayurvedic. This is Ayurvedic.
Okay.
Yeah, and we're also going to work with Tamil Nadu government now to test that Nilavembu Kudineer.
Yeah, exactly. They also have a herbal concoction, right?
Yes, for dengue, and papaya extract. And so actually some of these in the lab have shown antiviral activities. Now of course they need to be tested on dengue patients to see whether are they preventive or do they reduce the severity of disease. So I think there's no doubt that we need scientific validation of these claims, and then we'll have to accept the findings. It could be negative, it could be positive. So I think wherever there is these systems which are mostly oral systems, traditional systems, and of course they don't even use words like dengue and all in their systems because they have a very different approach to treating humans. It's a more systemic approach. But I think there's a lot of scope for us to work together. So we actually do have a partnership with Ayush. Things like turmeric, for example, now globally accepted, the health benefits of turmeric. And so we can do much more work on using turmeric, say, as an adjunct therapy for malaria or for TB or something. So these kind of studies, I think, can only be done in India. And the Chinese have an edge over us because they have been able to validate quite a lot of traditional Chinese medicine. Because they started many years ago and they had a very focused approach. So I think if we take that approach, we can probably validate and make globally acceptable some of these treatments, but I think there'll be many treatments where we may not find the evidence, and then we must be courageous enough to accept that.
I'm just, if there is a mood in the country, in the last many decades to explore these areas, I think the mood is certainly now. Over the last 3 years, we even had a separate ministry set up for traditional medicine with Ayush. However, when you talk to people who are skeptical about this, for them, their question is, why would you do clinical trials for a homeopathic cure for dengue when we already know so much about homeopathy? So even when you say if there are knowledge gaps, we need to bring the knowledge to it, or fill up those knowledge gaps. There are people who would say that this is actually criminal to even go this far, because what happens to people who put themselves through those trials, or what happens to all that money that was invested in something that by and large we know, for those who are skeptical about this, is not the solution. So earlier this year I had the opportunity to speak to the outgoing secretary of the Ayush Ministry, and he said, like what you said, which is that these things should often be adjunct and they should be along with something else, but there is also a mood here that says let's focus on this as the way, the truth and the life. So how do we sort of resolve this, in the sense, is this an expenditure well made? Is this ethical? Is this prudent in terms of our finances to be doing something like this when there's already a lot of evidence that says homeopathy may not do something of this sort?
So the way we approach it is we usually set up an expert committee that is composed of people with many different backgrounds and expertise to look at a particular problem, because you're right, and we also have limitations in terms of resources. We have to pick the high priority ones and work on that. So we would perhaps, if they came with a list of 80, we might pick 4 or 5 and say let's go ahead with clinical trials on these first, because the disease burden or because there's already evidence from long use. So far we haven't ventured into any homeopathy trials, but there are many things in Ayurveda, and similarly yoga has documented benefits in many conditions, particularly things like hypertension and diabetes also, where yoga can possibly have quite a lot of benefits. So here we feel that more clinical trials are needed to document.
Is with Ayurveda, Yoga, Unani Siddha and homeopathy, which are all the pillars of Ayush, homeopathy actually gets the largest amount of money. Where do you stand actually personally as a scientist on homeopathy? I mean, is this something that we need to explore further, or do you already have your conclusions on homeopathy?
Well, my personal opinion is that there is no scientific basis for homeopathy, and therefore there may be people who believe the opposite, but I would need to be convinced.
Strongly convinced?
Yes.
Of something which will really sort of go against the grain of the last many decades.
Exactly.
Right. Let me just end by asking you to be slightly, to speak about slightly more personal dimensions, but also political dimensions, which is what advice can we give young women about women doing well in the workplace, women being on top? What is it that's keeping women down? Because it's extremely heartening for me, to see that India will be represented at the WHO by a woman, like I was saying earlier on. So what is it that you have seen over your many, many years in public service, and what advice can you give young people who want to enter? If you can speak generally, but also about women in STEM.
Yeah. I think one thing is, of course, that right from the beginning, I think you should feel that you can achieve whatever your male counterpart or colleague can. Very often I think girls or young women tend to start off with the premise that they would have to take a little bit of a back seat because of the other demands of family that come up. So I think one thing is to be very clear that you can do both, just like men do both, and that we should be no different and be a little more ambitious. So very often we underrate ourselves and think that, well, I'm not really quite ready for that job, whereas a man in the same position thinks he's perfectly ready and approaches it very confidently, even though he may or may not be. So I don't know where women are more sensitive or whatever, but I think having a little more ambition, a little more confidence, and believing that you can do both justice to both family and career. At times you do have to make sacrifices, and I also think it's important that you need a supportive family. I think if the husband and family are not supportive, then it's really very hard for a woman to keep pushing against that. But I think now more and more, I think if you assert yourself, or if your family sees that you're so passionate about your job and your career, then I think they end up being quite supportive. So I think it's just and role models is the other thing, that in the past we haven't had too many role models, so we need to start really creating and talking more about role models for young school girls. Particularly, I've had a number of school kids write to me now saying that they want to take medicine and they want to do public health and so on. And then being represented at the leadership, I think we've seen now that there's been a conscious move to have women in selection committees, to look for women for top positions. Very often, I was at an interview today where there were 20 men and 1 woman who'd applied for this job. It was one of the directors of one of the leading institutions in the country. So this happens all the time, more in some like physics and maths and engineering, more in that. In the biological sciences and life sciences, particularly medicine, the ratio of women to men is much better. But even then, when you look around at directors, at vice chancellors, there you see a clear gender divide. So we're just not reaching for that top position because we feel that it's just not possible to do justice, I think. So it's more a mental
thing. When you say women underrate themselves, do you also feel like women have to perhaps do more, in the sense we also have to do double of what other people do? Or is it fine for us to, what has been your sort of mantra? Is it fine to just do your work and be honest about it and do a good job of your work, or do you have to do extra as a woman? What has been your experience?
No, I don't think you have to do extra. I think of course the ambience and in a particular place where you work, a lot depends on that. But I never felt that I had to do anything different as a woman to be recognized. So I think if you do your work and you do it well, then I think you will get credit for it. But it's important not to just take a back step. When the time comes, one should put oneself out there and be counted.
All right. Thank you so much, Dr. Swaminathan. Lovely to speak to you.
Thank you very much. Enjoyed it.